always tell patients it's a never ending condition. It's not something that you're going to defeat because it isn't a battle of I'm going to beat diabetes. No, it's I'm going to live with diabetes, and I'm not going to let it. I'm not going to let it consume me. I'm going to manage it. It's a manageable condition. As you mentioned in the early part of which part was reversible and preventable and everything like that. Diabetes is an extremely manageable condition as long as you're provided the necessary information to get you to where you need to be.
Yeah, and just like the foods, the complex carbs, diabetes is complex. And hopefully through this platform, we're able to show people like you really can't do it alone. You have
100%.
you have your provider who diagnosed you. You're going to have your nursing staff, whether that's in or outpatient. You're going to have your pharmacist, and hopefully you'll be in touch with a diabetic educator, because you guys have the bulk of education and the time, and you do it so often, that you're a great source of information, incredible, credible resource, which is what we try to promote here. So we've talked about so much about diabetes. How does someone get diagnosed? You mentioned A1C. So let's move into that direction.
I still have the floor.
Yeah.
Okay. Oh, awesome. Okay. All right. So with our diabetes diagnosis, we have to understand, how do we get here? Like, how in the world did we get here? Like, how did I find out that I have diabetes? Okay. Well, two big tests. One the patient can do, and the other the patient and the provider can do. One the provider does, and one the patient and the provider does. The one that is the most accurate when it comes to knowing a person's I guess you would call it level of diabetes control is the A1C test. The A1C test is essentially a reference point given a set of numbers to know whether or not a person has diabetes. It's the gold standard when it comes to diagnosing a person with pre-diabetes or diabetes. It's typically done inpatient, in clinic. They have some available for purchase that you can test yourself, but it's typically done in clinic. And depending on what the number is, it'll let you know how controlled or if you have diabetes or not. And this is kind of what gets us to this next piece. You start with normal. Normal is anything less than 5.7. So if I, as a person that does not have diabetes, the last time I checked, I will take a A1C test, and I will have a number that's less than 5.7. I will have a number that's less than 5.7. If I am suspected of having pre-diabetes, I'm gonna take an A1C test, and that reference range after I do that test is going to be between 5.7 and 6.4. That is going to put me in the pre-diabetic range, or I'm a person that lives with pre-diabetes. Anything higher than 6.4, that person from then on is considered having diabetes. Now, it gets a little bit tricky when it comes to, I'm pretty sure you guys have seen a person that says, "Oh, I don't even have diabetes anymore. It's like my diabetes is gone." They're not necessarily wrong in the sense that they are no longer with that 6.5. Like they're no longer 6.5 or greater. They may come in. They've done everything that you've said in clinic. They've done everything, done a tremendous job of following your education, your medication recommendations, and your prestigious working them up as a patient. And they come in 3 months later, which is typically how often the A1C test is done. They come in 3 months later and, oh my God, I have an A1C of 6.2. Oh my God, I don't have diabetes anymore. Technically, they still do, but the key point is they're now under control. And going back to what I said a moment ago, diabetes isn't a condition that you're trying to conquer. It's a condition that you want to manage. It's a condition that you want to control. And a person that is out of that reference range of greater than 6.5, anything greater than 6.5, anything less than 6.5, they're now considered controlled. Less than 7 is kind of what we live at in terms of the clinical standpoint. If they come in anything less than 7, they're doing a tremendous job of managing their diabetes. It also gets a little tricky, and I have to admit this, when they come in and they have that less than 7, which is kind of what we go for. They have less than 7, then automatically the question comes, well, I can stop taking my medicines now, right? Or I can stop, eating good and like do all these things. No, you can't. Because again, it goes back to, this isn't a condition that you're trying to conquer. Like after you, if this was a battle that you're trying to conquer, after that battle, you can just, put your swords and knife and your weapon down, right? But what happens when you do that? If you do that and you go back to your old ways, what's going to happen? The A1C is going to go back up. So it's not a battle. That lets you know that it's not a battle. This is a management game. And the more good days you have, the more you're going to show up every 3 months or however often you have your appointment with your diabetes educator or with your provider. When you have that test every 3 months, you're going to come in constantly with that less than 7, or ideally with that less than 6.5. And that's where the victory comes in at. Like that's when you have your victories. So it's really important. And this is another important piece I try to tell patients, is this is not something that you're going to win. And then all of a sudden you can just, go back to what you were doing in the past, because that's going to set you up for, that cyclical failure of, I'm less than 7, but now I take like 6 months to a year off. Then I come back and I'm at an 8, A1C of 8. And that's just no good. So that's diabetes. Pre-diabetes was still uncovering more and more information about pre-diabetes. One thing for certain that we know for sure is that more and more individuals in this day and age, with it being 2023 in a world of processed foods and everything done now, we have a lot of individuals that are living in that pre-diabetic range of 5.7 to 6.4. And that's just the reality of where we are. The only treatment available right now, according to the Diabetes Association, is exercise and lifestyle modification and a drug called metformin, and which is one of the gold standards of a patient that has diabetes. Also important to know with this condition right here, pre-diabetes is reversible. So you can go from that 5.7 to 6.4 and get less than that, and you no longer have pre-diabetes. But again, in my opinion, it doesn't mean that you should stop doing what you're doing when you got there. Maybe you can take the reins off a little bit because it's not as intense as that 6.5 or greater. But it's certainly a yellow flag when it comes to, okay, these are the things I know I have to do, because the one thing I don't want to do is fall into that 6.5. And of course, anything less than 5.7, you're considered technically normal. But the A1C has been our gold standard. It is an estimated average glucose that you also see that, but the hemoglobin A1C is the gold standard for diagnosis. And essentially, the reason they test it every 3 months is because that's about how long it takes for the red blood cells to reproduce themselves, so that you can see every 3 months what that number is going to look like. There are certain conditions that can alter what an A1C is going to be like. For example, like sickle cell, which is common in the African American community. Patients that have sickle cell, their red blood cells look a little bit different, and so the hemoglobin, the glucose that gets attached to that, the numbers can be a bit skewed in reference to that because of that anemia trait. But for the most part, this is our gold standard, and this is the number that we usually try to drill into patients, and the numbers based on the conditions that they have. This is kind of where we want them to be at. And
we just filmed an episode on sickle cell, so the audience should be quite familiar with that one.
Oh, that is awesome.
Yeah. So I love that you brought up the red blood cell turnover, because patients really get the A1C confused with the finger stick.
Mm-hmm.
And they're like, well, I ate cake yesterday. That's why my blood sugar is in the 300s. And that's why it's been like that for the last 5 days, is because of that piece of cake that I ate. And so as a nurse anyway, I constantly spend a lot of time explaining to them the difference between the A1C in that 3-month period, as opposed to the finger stick, and why we're going to give them this particular dose of insulin now versus what they might do at home, which might be a lot different, particularly when people are sick or they're on certain medications like steroids, which can alter their blood sugar.
Yeah. Absolutely. 100%,
And
100%.
so, like we had the little range there. Sometimes when people hit 5.7, the provider might start prescribing that metformin. One, because it can help you lose weight, which is one of the risk factors for diabetes, and that's like the main reason. Some people might even not even be there's a lot of things happening in diabetes medications today in terms of losing weight, and people aren't even diagnosed with diabetes, but there's a lot of evidence to support the use of that kind of off label, if you will. So because diabetes, like high blood pressure, can be asymptomatic or people don't have any symptoms on the outside, sometimes when they show up to us, their A1C is in the double digits. And I think, it's hard for people to realize that a 10 and a 7, while they're close numerically, are a huge difference in terms of disease management. And so this little chart here, it shows you your A1C. And basically that A1C is an average of what your blood sugar has been running over the last 3 months. And so even if you tell your provider that you've been doing something, the numbers don't lie. And they can look at this chart, look at your A1C, and they can see that basically for most days, if you're coming in at a 9, most of the time your blood sugar is running around the 200s. And so that A1C, while we did talk about it a lot, it is a blood test. And it's the regular needle that's going to go in a nice juicy vein, as opposed to the finger stick, which is typically we're going to use one of your fingers. Okay. And then we went into this. You pretty much covered all that. Oh, so there's our finger stick right there. And one time I thought about it. It's like, man, I always think, this is so easy. Let me just prick your finger. What's the big deal? And then I had to stop and think, like, would I be able to prick my own finger every day?
Yeah.
Like I had to stop and think about that. And I was like, I don't know if
Yeah.
I can really do that. I have to give a lot of credit to patients. And even, they start to develop those calluses over the years. And some people are quite sensitive, even though it's a very, very tiny needle. Some people are very quite sensitive to that.
Yeah, it can be crazy. Like I know that we had to part of the when I was doing residency training, one of the things that we had to do like basically was to experience the patient side of it, meaning that we had to be diabetic patients for 30 days and we had to test our blood sugar 3 times a day, just to kind of get into the mindset of what it's like. And what I found out from that 30 days, it can be tedious because I saw that from a standpoint of, okay, well, why didn't you test, why aren't you testing your blood sugar 3 times a day like you're supposed to, so we can get an accurate representation? Well, after doing that for 30 days, I can see life happens. And sometimes you just like forget. And it's not that you don't care about your health. It's just that life gets in the way sometimes. And so I think like learning that it better equip me to be less quick to lose faith in the patient because they're not compliant or adherent to the self checking of the blood sugar, because you have to consider that human component of sometimes you just forget, or sometimes things come up and you just miss it, and sometimes you just get tired of it, and that's just the reality of it. So I say that to say the fact that the patients do this is a huge component of it, and you have to consider that human factor when it comes to these things. One thing for us as providers to recommend that you test your blood sugar 5 times a day, but the patient is like, I gotta stick myself 5 times a day on top of these multiple injections and stuff like that. It's good to kind of have that in the mindset of, okay, well, I understand this can be a little bit difficult, so I'll allow you some grace, and I'm going to be less harsh when it comes to being considerate about how you approach it.
Yes,
I just had to mention that.
No, that's great. And so in terms of talking about, sticking your finger, you're right. And I'm so glad you had that opportunity to like experience the patient experience, because it made you more empathetic. And so often, patients will tell us we have such a hard job. And I always tell them, I've never been a patient. And I think actually you have the hardest job. I don't know what it's like to be in your position. And so it's nice when you have that opportunity, because it opens your eyes and it improves the kind of care you're able to provide and share with us, so we all get educated. But you're right, people get tired of sticking their finger. And so we have some really new, great technology out now where people don't have to stick their finger all the time. And so we know we have insulin pumps, and we have different sort of monitors that people can wear. Do you interact with that a lot in your role?
Not with CGMs. I think they have a huge space in it. I think that the individuals that use it, just to be completely fair, they're kind of hip to what's going on. Like they usually stay on top of things. It's the individuals that don't have the CG or continuous glucose monitors, that don't have those. You have to kind of provide them with that level of education. I try to push more patients to doing CGM because it gives you a more accurate representation over the long run of like what your blood sugar picture looks like throughout the day, throughout the week, and throughout the month until get seen in the next visit. They're not difficult to not it doesn't stand out like as you can see right here, and you guys see these all the times, whether you're in the market or just out somewhere, you see someone that has a CGM on. It's not anything crazy, and it's something that super convenient. I know it's super convenient as a practitioner. You can get a chance to see what it looks like when they're asleep, because that's a huge component as well. You get a chance to see what their fasting and 2-hour postprandial looks like, and it's really an interesting wave. Like when I went to my very first diabetes conference a few years ago, there was some buzz already about CGMs, but as I've gone these past few years, it's just gotten more and more and more when it comes to the presence of CGMs at these conferences, because the advantages are there, and with the technology that's accompanied with it, it's certainly the way to go. I know if I was a person that had diabetes, I know I would want to have a CGM available so that I can see in real time what's going on with my blood sugar.
Yeah, so
Without having
everyone,
to stick myself every day.
those of you watching the YouTube, we have a picture up of two women wearing a continuous glucose monitor. And so that transmits the blood sugar reading to a small device, like smaller than a cell phone, and it gives them the reading. And now, depending on what kind the patient has, they might still have to use insulin or take some kind of medication. But some people have an insulin pump. And so all they have to do is like hit a button and it'll automatically inject that insulin into them. So in the hospital, people are still allowed to wear them. Now, they might have to sign an agreement saying that they are able to manage it, that they have enough supplies, and that if something changes either with the reading or their orientation, that will take over, like if they go to surgery or they become altered. And I find that those patients, they do tend to be really on top of they're going to call me and say, look, this is where my blood sugar is. This is what I need to get. And those, that's a really nice relationship to have with someone when they have a really good understanding. And so I find I'm a big favor of them. I don't know what they do if the outpatient, if like in primary care or even the endocrinologist. I'm pretty sure they just trust the device and they might like interrogate it or something like that. But in the hospital, we still might check people's blood sugar. We still might stick them just to make sure we're getting the same reading. So people are always surprised by that because they've gotten so used to not getting stuck. And so sometimes that is kind of a bit of a sensitive topic, and we have to do quite a bit of education as to why that's happening. So just to close this out, I want to go over a few things we touched on, kind of like risk factors. We talked about diet, because people always say, well, grandma got, the sugar, so I'm going to get it. And they don't realize because grandma ate cornbread and rice every night, right? Because, even like in her Hispanics and Asian population, rice is huge, and it can be kind of challenging when you talk about like Mexican diets in terms of like getting the carbs down. I've talked to a lot of patients, and they're just like, it's really hard. You got your flour tortillas, we eat rice every night. And all the different dishes that they make. So in both communities, it can be quite challenging when you're trying to respect somebody's culture, but also help them decrease their risk. So we have diet, genetics, and those are those things, genetics, people can't do anything about. But there's so many things in the column that we can do something about, and hopefully you've gotten something out of that today. A big part of that, just like when we talk about high blood pressure, is diet and moving more than you sit. And then some of our complications that we see a lot, like in our slide we had before with the slow wound healing, and I think most people are familiar with when it comes to diabetes, is those amputations. And so one thing we always teach our patients, and you're welcome to chime in, is they always have to check their feet. So clean, dry skin that's moisturized will have a great skin barrier. As soon as it gets dry and you start getting those cracks and you start getting neuropathy or losing sensation in the feet, you're not going to notice that crack is there. Then you get dirt in there, you get a wound. It might be a really small wound, but you don't feel it. So you don't clean it, you don't take care of it. It gets infected. That's when we start to see you. And by then, we're doing antibiotics, and you're going to be on antibiotics longer than someone who doesn't have diabetes. And you're going to face more complications associated with those antibiotics than someone who doesn't have diabetes. And then sometimes those wounds, they take so long to heal. People get frustrated, or they're fatigued, or they have a big belly so they can't reach over and see their feet, or they live alone, or they don't change their shoes enough, or they don't go see their doctor enough, and nobody looks at their feet enough. And that's how we get to those amputations. And then people start getting depressed, and then the other complications just come on, right? We encourage them to go see their eye doctor, because that's one of the problems. Before you get blind, we want to stop that from progressing. And then we look at diabetes just like having heart disease, right? So it increases your risk for stroke and heart attack. And your diabetes can actually impair your kidneys, just like high blood pressure. And so those are like the big ones, typically that we see with diabetics. But because it affects your whole body, you can have problems. A big one that I think a lot of people don't know until they're a patient is gastroparesis, right? With our diabetic patients. And that's where you really just get a slowing down, an emptying of the stomach, and it becomes really painful. And in my experience, there's not a lot of options besides like the gastric pump. And even that's not really like a long-term solution. It's kind of just a temporary solution. Have you seen that?
I haven't. I mean, like in terms of treatment for it, no. But I would say the thing that as you were mentioning gastroparesis, maybe this is a topic for another show, but when it comes to like the medications that treat diabetes, a hot topic, and I know we're up against the clock, and I'm not going to talk too much about this topic, but the GLP agonist, glucagon-like peptide agonist. So your drugs like Ozempic and Wegovy and Trulicity, several of these. One of the side effects of these medications, people reported, losing weight, and that's one of the reasons why they're super hot and super common right now. But one of the mechanisms by which patients loses weight is that delayed gastric emptying, that gastroparesis. Like, so it's kind of crazy how one of the front runners in diabetes therapy right now, the GLP agonist, one of the side effects is that like delayed gastric emptying as a mechanism. I just thought that was kind of interesting right there. But when it comes to treatment altogether, there's not much available at this time.
Yeah, so we're going to just recap what we talked about today. This was a huge topic, and it's just a reflection of how big diabetes is. So if there's anything we've done today, hopefully we've encouraged you to do everything you can to not get diabetes. And if you have it, to talk to your healthcare professional so that you're educated, so that you can do what Dr. Smith has mentioned, and that's properly manage your diabetes. Here we like to say a diagnosis does not have to be a destination. So today we talked about what happens to your body when you have diabetes. We talked about complications associated with that. We named the test that we use to monitor your risk for diabetes. That's your hemoglobin A1C, and that's typically every 3 months. We discussed the numerical range for prediabetes and diabetes. So that's 5.7 to 6.4. And then if you're diabetic, you're usually at 6.5 and above. We identify what you can do to prevent it: exercise, watch what you're eating. Really go, and I'm going to put a resource in the show notes on a nutrition book that I absolutely love. It's taught by a dietitian, and it's really a free lecture, 17 hours of free lecture. And she goes over all your micro and macronutrients, because there's just no education in school when it comes to health literacy as well as nutrition. And so people are out here kind of driving blind, and we're kind of expecting them to know what to do. And I don't think that's really fair. And it's free. You can get it for free. And I'll put all the information in the show notes. We talked about some common symptoms you may experience if you have diabetes. We talked about the 3 Ps: polyuria, drinking too much, eating too much, and peeing too much. And then we talked about the diagnosis process. We thank Mark so much, Dr. Smith. Thank you for joining us, and happy belated birthday, by the way.
Thank you. Appreciate it.
Yeah, it's such an honor. I really reached out to him on social media, and he's been so gracious and kind. And really thankful to have your expertise here on this show and for you to represent Black male healthcare professionals. That does not go unnoticed by us here at the Melanin Initiative. Be sure to check the description box for a list of resources, everyone. Our email is there too, tmi.melanin@gmail.com. Make sure you subscribe to our YouTube channel and follow us on Instagram, TikTok, and Facebook. Tell a friend to tell a friend. After today's episode, make sure you tell your grandparents and your favorite retired adults as well. Remember, we release a new show. Oh, actually, you know what? We're at the end of season 1. And so you are our second to last episode for season 1. We will have a special in October on breast cancer, but season 2 officially kicks off in November. We'll continue to be active on Instagram and TikTok. You can continue to send your questions in through our email, and we'll answer them through our One Topic at a Time series here on YouTube. Alicia, did you want to add anything?
I think you've covered it all.
Dr. Smith, did you have any parting words?
Just, I'm extremely grateful for you guys having me. First and foremost, thank you all so much. And secondly, the work that you all are doing, I think is phenomenal for people that represent us, people like us, need to hear this information and let it get straight to them. So kudos to both of you for the preparation and the work and the communication. Means a lot to me to see this. So I just thank you all for having me. Really, really do appreciate it.
Thank you. And we would be remiss if we didn't mention Geraldine. She's our third co-host. She was not able to join us today, but her love is there and she's always with us in spirit. Thank you everyone for watching.